Yes, it's been really a great pleasure to be able to be here, visit with some friends, and listen to some great lectures like the last two. And you might wonder why are we talking about this? We're at a trauma conference. And I know most of you aren't surgeons, but what's happened in the field of trauma is we've turned into acute care surgeons. And what's been happening is that the specialty surgeons really don't want to take care of anybody sick. And so there's a disease called Perforated Diverticulitis that really falls under colorectal surgery. But when these patients get really sick, they go, oh no, the patient's too sick, send it to Dr. Moore. And this entity called Perforated Diverticulitis actually carries a significant morbidity and mortality, and it doesn't occur that often. And because of that, people have debated for almost a century about what you should do when you see this perforated colon. And so I'm going to kind of get into that with you. So I'm going to give you a historic perspective on this. I'm then going to review this in the context of our current approach in acute care surgery, which involves damage control. Then I'm going to talk about laparoscopic lavage versus resection. So when we talk about diverticulitis, basically what we're talking about, the left colon develops little sacs called diverticulum, and normally they perforate and the body seals it up, and you get some inflammation around your colon. You come into the hospital, doctor looks at you, gives you some antibiotics, and you get better. That's not what I'm talking about. I'm talking about the grade 3 and 4. In a grade 3 perforated diverticulitis, you perforate into your abdomen, you develop diffuse peritonitis, and that hole seals. And a 4 is called feculent peritonitis. You get a hole in your colon, which is big, it doesn't seal, and you have feces throughout your abdominal cavity, and you present in a very sick state. So the problem with Hinchey III and Hinchey IV diverticulitis is at presentation, they're difficult to differentiate. On CT scan, you see fluid in the abdomen, you see air, but you don't really know if there's a persistent hole. They're both very morbid, but a 4 is worse than a 3. Relatively rare, we see less than a case a month. And almost all the reports you see in the literature are case series, retrospective case series, and so the quality of the data is not that high. Historic perspective, Dr. Schreiber mentioned, I don't know if you noted that, but the Mayo brothers commented on war. Well, they're very famous surgeons, and the first person to ever operate on diverticulitis was Dr. Mayo in 1907. And he went in and resected the sigmoid colon and wrote it up, and people started operating. Now, interestingly, about 20 years later, his group came out and said, that's not a very good idea. If you go in and try to take out that colon, and this is before antibiotics, you really stirred up a big infection and the patient died, so don't do that. And so what they recommended is you just do a colostomy, where you just pull the colon up and decompress the colon, and you wait for some period of time, you irrigate out the colon, and at some point in the future, you may go in and cut out that colon. So that was kind of the state of the art until the mid-1940s, when there was this report out of Massachusetts, and this is really gave birth to what we call the 3-stage approach to diverticulitis. And I was taught to do this in the early 80s, which is when you come in, the first thing we do is basically go in and make a little loop colostomy. Just pull it out, give you antibiotics, wait about 3 months, go resect the colon, give you a colostomy, wait another 3 months, and then we hook you up. And so you can imagine that's could disrupt your lifestyle for a little while if that happened to you. In the late 50s, people started saying, well, maybe we can do this in 2 stages, and that's because the antibiotics came along. And people began to recognize, no, we can give antibiotics, get the patients better, and we can go in there and resect the colon, give the patient a colostomy, and that was called a Hartman's procedure. And Hartman was actually a cancer surgeon from the 20s, and that's how he handled upper rectal cancers. He just took out the upper rectal cancer and gave a colostomy. And so that's what a Hartman's procedure was. So for about the next 20 years, people argued about the 2-stage versus the 3-stage, and all these case series were put together, and it came out that when they put all these cases together, that the patients who got the 2-stage appeared to be doing better than the 3-stage. And this is when I was sort of in training, and we started thinking about that. But there are actually 2 randomized trials, very unusual for this field, and they showed different results. So that's the problem when you have small studies with something that's pretty rare. This study compared 3-stage to 2-stage, randomized trial, and 2-stage patients did worse. This study compared to 3-stage to 2-stage, and actually the 3-stage procedure did worse. And I highlighted this persistent peritonitis of 20%. So if you don't take out that colon, you're leaving an inflamed piece of colon there, and some people are going to have persistent inflammation in the abdomen, and they're not going to get better, and that's going to cause problems as you move along. Well, in the year 2000, the colorectal surgeons all came together and said, when you see this problem, what you need to do is a 2-stage Hartman's procedure. And this was at a time when they actually thought this was something that they owned. Now they would rather me own it. The subsequent reports came out. I don't know if, I suppose many of you know somebody who's had a colostomy, and most people don't like colostomies. And the problem is only about 50% of them ever get reversed, where they get sewn back up and now you don't have a colostomy. And that's because the people are pretty sick when they get these things. It's also, that colostomy takedown is a big operation. And so anyways, the colorectal surgeon started saying, well, these colostomies don't get taken down. Why don't we just do it as one big operation, a 1-stage procedure? Let's go in, resect it, do an anastomosis, and then maybe do a diverting ileostomy. And so this was sort of the debate in the 2000s, whether you do primary resection anastomosis versus this 2-stage Hartman's procedure. No randomized trial. Again, these are case series, patients just looking back and saying, doctors, this is what they did. And when you compare primary resection with anastomosis to Hartman's, when you look at these graphs, you've got to look at those little triangles at the bottom. It looks like primary resection anastomosis has less mortality. If you look at what we were talking about, greater Hinchey II, they're equivalent in mortality. And when you look at surgical complications, it looks like people who get primary resection anastomosis have less complications. So this big operation seems to do better than Hartman's. Now the problem is that if it's Friday night and you got an 80-year-old and they're really sick, you're not going to do a Hartman's procedure. I mean, you're not going to do a primary resection anastomosis. The surgeon's going to do a Hartman's. And so there's a big selection bias here where the sickest patients are actually getting that procedure. But it is noteworthy that the operative times for these 2 procedures are about the same. The primary resection anastomosis has a low anastomotic leak rate, and they have equivalent mortality. So in 2006, the colorectal surgeons came out and said, okay, you can either do primary resection anastomosis or you can do a Hartman's, and we don't know if you should do a proximal diverting ileostomy to protect the anastomosis. Now, subsequent to that, there actually was a randomized trial comparing the 2, Hartman's versus primary resection anastomosis, and in this trial, they found no big differences between the 2 approaches until you came around to closing the ostomy. So if you do a primary resection anastomosis, a lot of times you bring up what's called an ileostomy, and that ileostomy is a very easy operation to fix. Where a colostomy, where you have to open the patient up and do an anastomosis, is a big operation, and you can see that the ileostomies got reversed 90% of the time, the colostomy 57% of the time, and that colostomy closure was associated with a lot of more OR time, more serious complications, much more expensive. Sorry for my cough. So this is about 2012, and acute care surgery's booming away, and this is a problem that I'm seeing more and more of. And all of a sudden in the literature, somebody comes up and they say, hey, you don't have to do any of this big operation. All you need to do is stick a laparoscope in and wash out the abdomen with a bunch of fluid and put some drains in, and patients do really well. And so this report came out, and everybody went, wow, maybe I ought to try that. Now the problem is that most of these case series are just a few patients. And so there's a lot of selection bias. Maybe it was like the healthiest person you ever saw, you went in and lavaged, and you wouldn't ever do that with a sick patient. But the study that really caught everybody's attention was this one, because they actually had a protocol, and they subjected everybody who seemed to have this problem to a lavage. So they admitted about 1,250 patients over 7 years. 100 had evidence of this problem. They got resuscitated. They were taken to the operating room. They stuck the laparoscope in, and 8 of them, they found a big hole in the colon, and they said, okay, that's too big. We're going to cut that Hinchey IV out. But all the other people, they just washed out the abdomen, put some drains in, treated them with antibiotics, and the outcomes were remarkable. Only 3% of them died. In other reports, it would be 20%. 2 of them failed and needed either Hartman's or an IR drain. 88% resolved. And then they didn't offer them another operation after the surgery, which we typically do if you don't resect the colon. And only 2 of them ever had a problem after that. Now, that's a pretty remarkable report. And then a pretty famous colorectal surgeon named Franklin Morris, compared laparoscopic lavage to laparoscopic Hartman. So with a laparoscope, either you're just going to wash it out, or you're going to go in and you're going to resect that part of the colon. And he showed that the lavage patients did a lot better than the Hartmans. And there was only one report that sort of said, wait a second, this isn't as good as everybody's talking about. And this report was a Dutch report, and they had 38 patients that lavaged, and they said, hey, you know, about 20% of these patients, they don't do very well. And we do this lavage, and they get sick, and the problem is they have, I got some water, thank you. They have either a Hinchey IV, or they got a lot of comorbid disease. So this is about the time when the Western Trauma Association, which I'm a member of, decided that instead of just being trauma surgeons, maybe we ought to do something about acute care surgery. And so they volunteered me to become an expert on complicated diverticulitis, and I wrote an algorithm for this with the whole association. And then subsequent to that, the World Society of Emergency Surgery asked me to update that. And so I worked with some Europeans, and we came up with a consensus about how we should do this. And so this is the treatment algorithm that seems pretty complicated. And I'm going to step you through this. So first off, I'm not going to talk to you about grade 1, 2 disease. So we can just take that off the table. So I just want to talk about for the person who comes into the emergency room. You see them, they got peritonitis, they're in severe sepsis, septic shock. Get a CT scan, you get an X-ray, there's free air. And you have no doubt this patient's going to get an operation. You don't need to get a CAT scan if you don't have one. And the important question is the patient in septic shock? And what I was trained to do as a surgeon would be to take that patient immediately to the operating room. And what we've learned, that's not a very good idea. And what you really need to do is do a little optimization. And that takes about 2 to 3 hours. And what this really comes from is from the Surviving Sepsis campaign, which I mentioned the other day, about applying evidence-based care. And so when I was in Houston with Dr. Suker, we became very interested in this Surviving Sepsis campaign, and we developed a screening tool, and we developed a computerized decision support, and we implemented this protocol, and some of these people had this problem. And what we demonstrated was, if you could just get in there early and recognize sepsis and resuscitate patients, you could dramatically reduce mortality. And when we were trying to figure out what were we doing to improve mortality, it turns out that if you can prevent acute kidney injury, so a lot of these people come in, they're in septic shock, their creatinines are elevated. If you take them to the operating room and don't resuscitate them, and they go into further shock, they develop acute kidney injury. Once they develop acute kidney injury, they're in for it. They're going to be in the ICU for a month, and they're going to be really sick. So the idea is to do this preoperative optimization to really get them volume loaded. So put them in the ICU, give them 3-4 liters of crystalloid, put your lines in, make sure their antibiotics are on board, then you take them to the operating room. When you get to the operating room, and what happens is the anesthesiologist gives them medications that vasodilate them. So all of a sudden, they could go back into septic shock and look terrible. So if you put them to sleep and all of a sudden they look terrible, well, it's time to switch to a different idea that I'm not here to do like a definitive operation, I'm going to do damage control. And you've seen some variation of this yesterday with Dr. Bensard. We as trauma surgeons feel very comfortable about doing damage control, and when we're doing it for trauma, we're usually doing it because the patient's bleeding to death. Well, these people aren't bleeding to death, so we're not doing damage control in this patient because they're going to bleed to death. It's because they have a persistent septic shock problem, and you've resuscitated them, and they got this colon that needs to be taken out for you to control the sepsis. And so what you're really trying to do is to break this cycle by resecting the diseased colon. And so what we do in this situation is not a definitive resection. So the sigmoid colon is probably about that long. And when you try to remove it, you have to go down into the pelvis. It could be a big operation. The perforation is generally up high, and if you just take the colon and pull it out of the abdomen, you can just go and cut it out, and that operation can be done in 20 minutes. And so what we do is just a perforectomy, leave the patient in discontinuity, and come back another day. Now we take them back to the ICU, we optimize things, then we bring the patient back, and we decide, are we going to do an anastomosis at this point or not? And it's a very debatable thing because the reports in the literature is the leak rate is anywhere from 7 to 30%. And if it's really 30%, doing an anastomosis is probably not a very smart thing. But if everything looked good, you could probably hook them back up. So if you don't have this septic shock problem, you take the patient to the operating room, they put them to sleep, they're not in septic shock. Well, what would you do? Well, you stick a scope in, and you look around. And when you look around, if you think the patient's low risk, we recommended that you do lavage. And if the patient's high risk, then we would recommend that you do a definitive resection. So that means you're going to either do laparoscopic resection of the colon, or you're going to open up the abdomen, resect the colon, and do it, but you're going to cut that colon out. So that was sort of the state of the art in 2013. And then all of a sudden in Europe, something that's never happened before is people started doing randomized trials about this problem. And so since 2014, there have been 3 prospective randomized studies that have looked at this laparoscopic lavage versus resection. And I'm not going to spend a lot of time on this, but because it would be very interesting for the surgeons. But The long and short of it, the first study was stopped early because the lavage patients had a lot of early adverse events. And it turns out that about 20% of patients required, they got the lavage, but they required another operation. And most of those patients had a Hinchey IV. So that the surgeon went in, laparoscoped them and said, I don't see a hole, lavaged them, but they were wrong. The patient actually had a hole. And then they had to get an operation. So that wasn't very good. But when they looked long-term at a year, and you added in the colostomy closure on the patients who got a resection versus the laparoscopic, it was a wash at the end. But the hypothesis of the study was that lavage was better than the resection approach, and the conclusion is, no, that's not true. And so most surgeons, when they saw this report, said, oh, I guess we shouldn't be doing this lavage thing anymore. But in reality, if you read the papers, you realize the problem is if you miss a Hinchey IV, then that's the problem. And when you go in and do the lavage, you've got to really look at the colon and make sure there's not a hole. And if you don't have a hole and you get lavaged, well, three-fourths of the patients do just fine and never get a colostomy. And so if it's me, I'd probably want to be one of those people versus having a colostomy. And if you look out at 12 months, it's kind of a wash. Well, the second study was a Sandive trial, and they compared lavage to resection, found no difference between the two. Then when they went out and looked at at a later, well, if you look and say what happened short term, it's not surprising that there's more wound infections when you open somebody up and do a open up somebody and do a resection versus if you lavage and you're washing out the abdomen, you're going to have more intra-abdominal infections. And this study came out again and said, well, it doesn't really support lavage, but if you look at the data, you'd say, well, again, most of these people actually do all right to get a lavage. It's just a subgroup that don't. And then this study was a pretty good study, Hinchey III, 83 patients, and they compared lavage to resection and showed lavage, as you would expect, had a lot less operative time, less hospital days, equivalent mortality, equivalent second operations. If you look at primary outcome at 12 months, so after you put all the patients going back and getting their colostomy closure that got a resection, the patients who got the lavage got less operations, less days in the hospital, less serious complications, and this would be in support of doing this. Well, because we had written these two algorithms, we were asked to make a comment on this, and so we wrote this opinion. And our opinion was that lavage is still an option in low-risk patients. You eliminate the need for a colostomy and a second operation. The problem is if you choose to go down that path, about 20% of patients are going to fail. And so the problem is what people do is they don't recognize that the patient's failing. So if you're going to do a lavage, you've got to follow the patients very closely. If they're not doing well, then just go do the resection. If you wait until they go back into septic shock, that's not going to be very good. And the problem is missing this Hinchey IV. So when you do a lavage, you got to go look at the colon and actually manipulate it and look for the hole. And some people go in when they do the lavage and they don't want to disturb anything, and that's a mistake. And if you do a lavage on somebody and they don't get a resection, it's very important that they get a post-op colonoscopy because cancers often present as a perforation. So about 5% of these patients will actually have a colon cancer. And when you do lavage, if you don't do a colonoscopy and diagnose that, at some point they're going to come back. And then there's a big debate whether you need to do a delayed elective resection in these people who respond. So I'll leave it at that and be happy to answer any questions. And I'm sorry for my cough.